Good afternoon, everyone. Thank you for joining us and welcome to our third CMM Insight webinar in association with the National Care Forum. We're really pleased to be able to bring together colleagues from the National Care Forum, joined by ICS leaders and the Department of Health and Social Care today to discuss integrated care systems now they're 1 year old. We really want to hear from you during these discussions. They are for you, so please send us through your questions. If I can ask you to do so using the Q&A function at the bottom of the screen, this just allows us to keep an eye on those questions, and any that we can answer directly we will, but also the speakers will answer those for you throughout the session. Today's session is recorded, so it will be able to view it on the CMM website next week when that's uploaded to the site, and it is also CPD registered, so you can claim points by watching the session today. Before I hand over to our speakers to start the session, we have a short film to play from our kind sponsors of the day, Planday. You'll find all of their details on the CMM website afterwards as well, for anybody wishing to get in touch. So if you can watch the video for us, and any feedback will be gratefully received. We'll just put that on now for you.
Planday from Zero handles workforce management complexity so you don't have to. It handles your rota, your time tracking, your comms, your payroll data, and your reporting. Planday also improves compliance confidence from anywhere, anytime, and on any device. Planday makes your shift scheduling faster, flexible, and easier to manage. Because it's cloud-based, changes to the work schedule, information about your business and the updates your staff need are shared in an instant. By using Planday's employee scheduling software, you can dramatically reduce the amount of time you spend making a schedule by automating more of your processes and empowering your staff. Staff set their availability, they can change and swap shifts with each other, and request holiday and sick leave, all in the app. Planday's punch clock tracks your staff hours right down to the minute. Staff get reminders to clock out, and you can include a GPS radius or use the IP address of your business, so you know someone's on site. You'll easily be able to review and then approve timesheets, which gives you an overview of the hours worked and your payroll costs. After you've approved a timesheet, simply sync it to your payroll provider. Planday connects your staff schedule and hours worked with hundreds of payroll and point-of-sale systems, so you get the insight you need into business performance. You can adjust your staff levels or your schedule based on revenue and run smart reports. This means you'll have the right level of staffing and the right people working to suit your business needs. And through it all, Planday empowers instant and better communication, with messaging, events, and email communication through the app. Your staff are always connected, so you can share information with the right people in the right place. Small business has a big future. Planday, make your day work.
That's great. Thanks so much for Planday for their support for this event today. So I'm going to hand over to our speakers now. We're going to be, Liz will be chairing for us from the National Care Forum, and I will hand over so you can all introduce yourselves. Thank you so much.
Thanks, Lisa, and thanks for that rather jazzy little reel. There's a technology solution for everything, isn't there? Marvellous. So welcome everybody. My name's Liz Jones. I'm the Policy Director at the National Care Forum. We are the membership association for not-for-profit providers of care and support services. And we're delighted to be working with CMM in partnership, hosting a whole programme of webinars. And today our focus is around integrated care systems. It's a year-ish, not quite to the day, that integrated care systems became a statutory thing. So we know that in some areas they've been around for a while, but it was a year ago-ish that they became a thing that happens in every place in England. So I've got some esteemed colleagues on the call who are going to help us reflect on what that year's been like, and help us think about what we might want to do and plan for the year ahead. It's always good to take stock, especially with such a big system change, I think, and a big potential opportunity for joining up health and social care. So I will ask my colleagues to introduce themselves. I'll go to Rima first.
Hi, I'm Rima McCarrum. I chair Bedfordshire, Luton and Milton Keynes Integrated Care System. I also chair Sue Ryder, so I sit on both sides of the fence, as it were, so I understand a lot of the questions that you might ask today from my one hat and the answers from the other hat.
Thank you. We're delighted you'll be able to swap metaphorical hats regularly throughout the session. Frances?
Hello everybody, I'm Frances Newell. I work in the team at NHS England, which supports policy and implementation for integrated care systems, and I'm head of partnership development in that team, so looking at supporting NHS collaboration with non-NHS partners such as local government, social care and the voluntary community and social enterprise sector.
Thank you. So we've got our NHS guru, Jason.
Hello, I'm Jason Yannick. I'm the Director of Systems Integration and Reform in the Department of Health and Social Care. And my team sort of took the legislation through that got us to last July, but we're also responsible for ICS policy in the round, so ministerial interactions with ICSs, enablers of them, and so on. We're also somewhat involved in the Hewitt review, and are working at the moment on the major conditions strategy, which I have come to discover is also an integration strategy as well.
Oh, certainly, as it's currently framed, for sure. Thank you, Jason. So we've got the DHSC perspective, and Nathan.
Afternoon, everyone. I work with Liz, so I'm the Senior Policy and External Affairs Lead at the National Care Forum, and I've been, I guess, working with our members and thinking about how they engage with integrated care systems over the last year. So I'll hopefully be able to share some of the insights, some barriers, some top tips, that sort of thing on today's call.
Brilliant. Thank you. Thanks, everybody. And we really appreciate your time today to run the webinar. And I know Lisa make sure that the webinars are available for catch up afterwards. So thank you very much. We really appreciate it. So we've got about an hour and a half-ish to work our way through some of our reflections. And we've decided to kind of chunk our discussion into three main sections. So we're going to kick off with a bit of scene setting. So we're going to hear from our respective colleagues about kind of where we are, and also a bit of the kind of hard-edged reality from Rima of the challenges facing systems, and thinking about being at the start of that journey. And then we're going to spend a little bit of time thinking about the partnerships angle and thinking about what we need to think about, what we need to plan for if we as social care providers are seeking to build our partnership credentials and our partnerships in practice in local systems. So how has it been? What can we think about in future? How are things evolving? And then we're going to spend our last 20 to 30 minutes-ish thinking about looking ahead for year 2 of integrated care systems. Perhaps bring some hopes from the provider sector, and also take reflections from our participants if they have got some ideas. For participants, as Lisa said, there's a Q&A button at the bottom of your screen that's next to the chat button. So please do pop your questions in as our speakers are reflecting in the various sessions. I know that I have to ask my questions as soon as I think about them, because then the discussion moves on and I've forgotten what I was going to ask. So feel free to make use of the Q&A for specific questions. Reflections are also good, but you might want to pop reflections in the chat. And if you want to tell us what organisation you're from, feel free to, don't feel you have to. It's always good to know who's listening. So we're going to move into our kind of first 20 to 30 minutes chunk, which is our scene setting chunk. So our colleagues from the NHS and from the Department of Health and Social Care are just going to kind of refresh our audience of where we are with ICSs and kind of what's in place and the work that they've been doing to help with the strategies that ICSs have to create and some of the resources that have been available to support ICSs in their partnership role. And then Rima's going to give us a bit of the hard-edged reality of the perspective of a chair of an ICS. So it will be great. Okay, so I'm going to stop talking. Who's going to go first from Francis and Jason?
I believe it's Jason starting.
I think that's right. Yes, I think that's right. Very good. Well, thank you. And Liz, you've already made one of the points I was going to make, because I was going to slightly query the 1 year on bit and say, in some ways we are 1 year on. In other respects, many systems are more than 1 year on, because some of a lot of this came from work that people had been doing for some time, at least as far back as sustainability and transformation plans / partnerships, which some people will remember. And I make that point not just out of pedantry, although goes with the job a little bit, but also because there is a lot of, if you like, positive history and people trying to make this work in practice that came before we got into the legislative space. It's not always like that. I think it's one of the strengths of this particular framing for the system that we did have some time where people were actually giving, albeit in a non-statutory form, giving this a bit of a go. That doesn't mean there aren't lots of challenges and questions and difficulties ahead. I think there are plenty of those. I'm sure we'll talk about those a lot, but I think that is one of the strengths of all of this, and I can say that because it wasn't us that did it. It was really a combination of circumstance, NHS England's good work with colleagues in the system, and actually people getting on with doing some of this just in order to deliver better care. And I suppose the other general point I'd want to make up front, it links to something that's in the air at the moment, which is the 75th anniversary of the NHS. A lot of people looking back over a long period, and we had a talk recently by someone called Andrew Seaton in the department, who is a historian of healthcare, and one of the points he was making really was that very often the story of change in the system is told in terms of white papers and legislation and all of that, and there's this whole other set of things going on out there, technological change, social change, institutional sort of evolution and so on, which is often what's really going on, and it's the interaction between the two is what's really important. And so one of the things that we've been trying to do really over this year in the department is, rather than sort of, as it were, playing with the train set too much, is more sort of getting to know systems, what's going on in them, how they're forming and shaping themselves, rather than sort of leaping to conclusions about whether they've succeeded or not, because it's very, very early days still. And I think one of the things that we've been most interested in, and indeed issued a bit of guidance for, is the integrated care strategies that the ICP develops. The ICP being the broader bit of the system that draws in a wider range of partners than the more sort of, if you like, NHS money holding bit, the ICB, which Francis, I'm sure, will say a bit more about. And it's the working of those two elements together that is, I think, going to potentially drive quite a lot of the value into integrated care systems. So we've been sort of looking to be sort of supportive and really understand, if you like, what's going on, trying to start with that rather than leap to answers. Having said that, we were also involved in and asked to help with the Hewitt review, and it was sometimes called the Hewitt review of ICSs. I think it's better characterised as, if you like, a review for ICSs. It was people were slightly worried at the beginning that this was a review sort of a few months in as to whether ICSs were a good idea. And actually, the terms of reference and indeed Patricia herself were very clear that this was about how to make them work as well as possible, and what we might need to do to support them. And actually, one of the things that has persisted to what has been quite a difficult year in various ways operationally, sort of across a very broad span of opinion, and people who sort of have decision-making power in the system, is a commitment to system working and to ICSs in the form that they've now taken. They will no doubt evolve. Models, different types of them will emerge, because we're not sort of saying there is a single way of doing it. Some will be more perhaps rooted in place, some will be more kind of interested in using provider collaboration as a way of driving forward change. Some will do more at system level. There will be differences that go with geography and go with sort of social factors as well. Coastal communities versus metropolitan communities, very different things. Rural communities are very different again. So I think we probably expect to see an evolution of different types as time goes on, building on the work that's been done this year around governance and constitutions. So some of that can seem quite dry, but I think it's quite important that some of that is now in place. The other element that I think we're starting to see examples of, seeing some of the similarities between some of the strategies as well, but I think is again an area of promise and potential development, is the use of systems as sort of learning machines or learning mechanisms, sharing with each other some of the insights that they're developing as time goes on, both across the broad expanse of responsibilities they've got, and also on the NHS side as well. And I think that's where potentially some of the partnerships with colleagues from social care can really start to make a difference. And although it can seem quite, if you like, quite NHS-y quite a lot of the time at the moment because of some of the pressures that we all know about on the system, I think it's also true, and partly comes out in some of the work we're doing on major conditions, that many of the answers for some of the most pressing and difficult problems of access and sort of management of flow and all of that in hospitals actually lie outside of the hospital door, whether in social care, community care, prevention, and beyond, indeed the local economy as well. So it feels like a sort of, both operationally and strategically, there is a very strong sense of what you might call both and rather than either or. And although both and is probably in some ways more difficult, I think the connection between the different elements is really, really well understood, even if it's going to take a lot of work pathway by pathway to actually start to make a difference to outcomes for patients. So I think sort of, if you like, a really good start. Loads more to do, loads of challenges. I think we've got a really good foundation, but I wouldn't want to underestimate the sort of depth and breadth of the challenges. I'll perhaps stop there.
Thank you. And I think that NHSE point is quite relevant for us, really, in the sense that, as you say, many of the solutions to those challenges for our collective populations around their health and well-being outcomes actually lie quite beyond the NHS. They have a key role to play, but actually certainly the people we represent and lots of the folks across the social care sector, perhaps they don't articulate enough their role in some of those key things, particularly around prevention. But yeah, I think they would, when asked to describe it, I think they would get to it. Whether they would initiate the conversation is a question for us, really, and Nathan might reflect on that a bit later. So Francis, from an NHS perspective, where do you feel we are, and what's been, I know your team have been working really hard to try and kind of support that partnership working. So what would you like to be sharing with our audience?
Hi everybody, thanks Liz. And Lisa, would you be okay to share the slides at this stage? So going on straight away to the second slide. I thought it might be useful just to remind ourselves of the kind of 4 purposes of integrated care systems, which you can see there on the right, and just to kind of reminder really of the structure of integrated care systems. There's a statutory element that Jason's referred to, the Integrated Care Board and the Integrated Care Partnership, which is really the place where those wider partners can come together to particularly look at the role of all partners, because I think, as Jason's emphasised and Liz has also just mentioned, collaboration's at the heart of these new structures and the new arrangements, and that's whether it's at the kind of system-wide level that's covered by the ICB and the ICP, but also the kind of interactions that happen at that place or local authority footprint, and then in kind of neighbourhood localities, where again, kind of echoing what Jason said, the partnership arrangements do vary a lot depending on the kind of geography and footprint of systems. But I think kind of cutting across all 42 systems, there's sort of recognition. Of course, we've just celebrated the 75th anniversary of the NHS. We're very proud of what the NHS has achieved in its first 75 years, but there's also recognition that there's enormous challenges facing the health and care sector, and those challenges can't be sort of met by one partner alone, and that collaboration is the answer, whether that's kind of collaboration across organisational boundaries or across professional boundaries. I think one of the significant milestones in the first year of ICSs has been that Integrated Care Partnerships has produced their first integrated care strategy, which is supposed to reflect the kind of priorities for health and well-being of wider partners across the system. And then the kind of NHS body, the Integrated Care Board, is taking the priorities out of those integrated care strategies and reflecting them in their joint forward plans. And one of the things that we have worked with colleagues at the department on, and local governments, and also the Care Provider Alliance, is to really kind of reflect expectations for the importance of those wider partnerships. So Lisa, if you wouldn't mind moving us on to the next slide. We set out some expectations for how the importance of kind of partnership working to allow services to really be planned and provided with that wider partnership perspective. I think one of the other things we've been doing, we know how important adult social care providers are as a strategic partner. The size of the social care workforce and the millions of people across the country that kind of draw on care and support from social care providers. One of the things we've done in the first sort of year of statutory operation of ICSs is we've partnered with the Care Provider Alliance to really kind of use a national platform to try and share and spread local innovation as to where those partnerships, spotlighting where those partnerships are working well, and kind of highlighting the shared agenda for partnership working. I think it's fair to say that it's early days. There are some areas where those partnerships and collaboration are working really well, and other areas where partners would like them to be a lot stronger than they are, and we continue to work on that. The next slide, please, Lisa. One of the things we did last year was really take a close look at what were the challenges and the opportunities for specifically how integrated care, how the adult social care providers are sort of involved as a strategic partner in ICSs. And it was clear that there was a lot of enthusiasm in the sector to really kind of seize this opportunity. And there are, of course, enormous shared agendas, which we've kind of highlighted in the middle of the slide there, where we won't get all of these areas right unless we've got adult social care commissioners and providers fully engaged and involved. but there are some challenges in doing that as well. There was certainly a view from providers last year that they hadn't necessarily been as actively involved as they would have liked in the establishment of ICSs to date, and Liz and partners have strongly advocated for that voice and strategic input in the kind of national stakeholder conversations that we have. And I think there's a recognition that it's a large sector, and the kind of size and diversity and some of the differences in behaviour and cultures can make that collaboration and building those stronger relationships difficult. But I think we're continuing to strengthen that collaboration with providers. So we're building it into various work streams. You may have come across the intermediate care front runner pilots, where we've put some work into making sure that social care providers have kind of got a strategic co-design voice in how those pilots are designed and delivered. I mentioned the work we're doing with Care Provider Alliance on our ICS and social care learning network to really spotlight and share some of that good practice. And we're doing some work with Skills for Care and taking a look at what are some of the kind of engagement models that are working well in systems, and can we share and spread those engagement models, recognizing that different systems have got different ways of approaching this, but there are some sort of helpful examples of leading practice that we think we can usefully share, and we're working with Skills for Care to kind of pilot some approaches to that as well and support that. And then of course at national level we continue to work really closely with social care stakeholders, both on the commissioner and provider side, to kind of strengthen those national relationships across the range of priority work streams that we've got in NHS England, and for the support that we're giving ICBs kind of in the first year and beyond, because obviously at national level we want to kind of model the collaborative behaviours that we're setting expectations for in systems. So those are some kind of reflections on what we've been doing in the first year of statutory establishment and some of the opportunities and challenges. There's a little bit more to say about kind of the detailed work that's going on in systems, but I think we're going to come on to that later. So I will pause at that point. And I think it's also the point to stop sharing the slides.
Thank you, Frances. And just to, are there any plans? You mentioned the integrated care strategies. Are there any plans for any kind of review of those or oversight of those, or anyone doing a handy summary so you don't have to read it all if you work across a number of ICS localities?
So we have done a bit of work nationally with partners in the local government, LGA, and in Confeds, to sort of take a look across those strategies and look at the themes that are coming out.
Thank you. That would be really useful. So we've heard from our policy gurus. Now we're going to hear from the woman at the hard edge of the reality of running an integrated care system. Well, at least chairing an integrated care system. So Rima, do you want to give us a perspective from the last year of kind of how it feels out in the field?
Yeah, absolutely. So I've been chairing this particular system for about 3 years, actually. So as Jason said, they haven't just come into existence. But it's a very different place. And I think we can't underestimate how difficult it is to make any of this happen if the partners in the patch don't want to work together. So I think I spent the first year just convincing people to be around the table and to talk to each other and talk to each other nicely. And now we've got past that, we are actually starting to make a big difference in the way, a big shift in the way that we work together. But just to give you an idea of the complexity, on the basis of our population, that's about 1 million people, we're put into the smallest category of system in the country. However, to give you an idea of complexity, we have 4 councils that span the entire spectrum of political rainbow. We have 4 health watches, 4 health and wellbeing boards, 2 ambulances, 2 acutes over 3 sites. We have 97 GP practices. Who have I forgotten? We've got 2 mental health providers, 2 community health providers, and well over 4,000 voluntary and community and social enterprise organisations. And that's a small system. And everybody wants to know why they're not around the table. We haven't got room big enough for all of those people. So that's, that's just to give you an idea of, not only is it complex in terms of the mandated governance, which looks great on paper and is really difficult to make work in practice, but at the same time, there are just so many people that you need to get around the table. Jason talked about rural and coastal. We have everything apart from coastal, but we have very, very deprived areas, for example, in Luton, where they're so poor that the council's ambition is to eradicate poverty by 2040. And just next door, in much more rural, white affluent central Bedfordshire, they're worrying about other things like, why do children from that background not attain the educational standard they should attain at that level? So completely different problems, completely different demographics, completely different population behaviours. And I think that we can't underestimate that if our population doesn't behave according to the theory on the paper, you can't make it happen. So in Luton, because they can't take time off, their 0 contract hour contracts, they can't necessarily take their wives to London for their radiotherapy. So those wives go on palliative care pathways instead. And that is the reality of what kind of things we're trying to work with. I absolutely want to do this job to make a difference to the population's health. I don't want to make it easier to discharge from hospital or to get people to the GP. Of course I do, but that isn't why I'm doing the job. I'm doing the job because they shouldn't want to need the GP or the hospital in the first place. If we can work together in this partnership to keep people well, to help them manage chronic conditions so they don't hit a crisis, so that vulnerable families are supported, so that their own children don't end up embarking on a totally different pathway in life because they weren't supported as a family and then those children in school. So there are, and I noticed Francis talks a lot about adult social services. We're doing a lot with children as well, because if you don't make a difference at that stage, that's it, you've lost another generation. So I'm very passionate about making that difference. The challenges this year have been multiple. So it's a little bit like trying to set up a startup. You've got more money, but you've got limited leeway in how you spend it because there are various buckets and ring fencing and lots of rules that allow you to spend it in one way but not in another. We've obviously had the cost of living crisis. So we've had programs of work, for example, keeping houses warm. We've put money into that to keep our population warm so that they don't become ill. We obviously have all the industrial action ongoing, and everybody will know the NHS is a little bit quirky in that you employ people, but you can't set their terms and conditions, and you just hope that others will sort out the problems so that your people come back to work. And that, of course, is impacting on elective recovery. And of course, government doesn't want us to keep talking about the fact that nobody can see a GP and that all the operations are being cancelled. And that tends to be the national focus that's pushed onto the ICSs to fix. But of course, we don't have enough of the levers to fix all of that. So my system actually does quite well. And then we get stalled by the fact that, yes, gave us some more strikes, and then we try and catch up again. It is a distraction for getting onto the bigger piece, which is about that prevention. We also have various funding pressures in terms of estates and capital estates. While I won't go into the nitty-gritty of what happens behind the scenes with politicians, but where it matters to them, we can unlock money, and where it doesn't, it's more difficult. And again, when you try and balance that with health inequalities, that can be tricky. Having said all that, with having to set up the governance and dealing with these immediate issues, and I also forget that we've got Luton Airport, so we also have to worry about every group of refugees that comes in through Luton Airport, and make sure that they're supported and housed and get the medical treatment they need when they arrive. So there's basically quite a lot of external pressure. Despite that, relationships between the partners are great now. There are various collaboratives. The local authorities who initially thought this was all about the NHS are buying more and more into the fact that it's not really about the NHS. The NHS can only help 20% of an individual's health and well-being. The other 80% is everything else that they control, where people live, their access to education, how we help lifestyle behaviours. So are we putting too many junk shops out, and do people have access to a leisure centre and green spaces? A lot of that's in their control. So by working together, that is really starting to open up new possibilities and new ways of doing things. We're working very closely with the VCSE. We have a memorandum of understanding with them now. The thing I think that is really tricky is that it's only year one. We're still learning how to do these things, and we can't do everything in one go. So we have very big aspirations, but we also need to be more focused. Otherwise we'll end up delivering nothing. We'll do a bit of everything and not enough of any one thing to make that impact. And I know that's really frustrating for a lot of people probably on this call. I cannot tell you how frequently I get emails saying, why aren't you looking at this little piece and that little piece and that little piece? And then of course we get more national mandates. And at the same time, we've been asked to cut our running costs by 30%. So, we're basically having to lose lots of people to be able to deliver this. So everybody wants it to be a bigger agenda with fewer and fewer people and less money. It is quite a balance. We will get there. I'm not pessimistic. It's just the expectation of how long it's going to take us to get there. Giving us dental commissioning, for example, doesn't mean we suddenly have NHS dentists on every street. There are bigger issues, and that's just an example of how things are going to take time to shift. I'll leave it at that point.
Thank you. You make it sound a little bit like trying to juggle plates on a unicycle going uphill in a bit of a fog. Oh yeah, the dental commissioning was interesting. You've reminded me, Rima, actually, and Francis's slides reminded me about the one of the 4 aims of ICSs around that broader social and economic development. And I'm old enough to remember back in the day sustainable community strategies and sustainable community partnerships and local area agreements and things that were all about driving some of that change that you describe now through those mechanisms and frameworks. So it's really interesting to hear the reality of one particular local system and the diversity it's trying to manage, I guess, and support, and particularly thinking about, if you're one of those 4,000 VCSE providers, then kind of looking at that whole landscape is probably quite challenging. So that is really a really useful scene setter for us, I think. Thank you. It sort of brings the realities of it all home a bit, really, as well as 4 councils with all different political colours. Equally a challenge. And councillors' views about their role in all of this. So, okay, so I think we've got our scene set, and we've got a good springboard for thinking how we build on that partnership element that you mentioned, Rima. That was, you're 3 years into that partnership building and that partnership working. So Nathan, do you want to give us a bit of the kind of NCF membership perspective?
Yes,
building on what we've heard from our colleagues.
Yeah, so I think I'm going to give some reflection, kind of what our members have been seeing over the last year, and I certainly agree. With what Rima and Jason and Francis said about that need to shift to the prevention side of things. That's something that's very much at the forefront of our members' organisations, but also they're also as social care providers quite strategic partners in doing that. So we look at those, those 4 main aims. Every area of the country is going to have adult social care services. In many cases, those social care services are going to be interacting with people on a much more regular basis than perhaps some bits of the NHS are. So there's a lot of overlap and working that needs to happen in terms of working together, and for ICSs to see that sort of strategic level. I just want to take one step back first and just, I guess, illustrate how important ICSs are for social care and why it's important for social care providers to be involved in them, and thinking about that particularly in terms of the whole reform agenda that's stalled a little bit at the moment, but I think integration is a central part of that. So we've already heard a little bit about the Hewitt review on the call. There was also a review by the Health and Social Care Select Committee, which had very similar findings. Again, need to shift to prevention, and then also both reports talk about some concerns raised by providers about representation within the systems at the highest levels, and that's something we've heard time and time again from our members, because I think when the systems were first put on a statutory sort of basis last year, there was just some concern about how providers have their voices heard and how people accessing services get their voices heard in the systems. And so we've been working with DHSC and with NHSC over the last year to try and find some ways around this. And I think, you know, the other important thing to bear in mind as well, last Friday we saw an NHSC long-term workforce plan. There's very much obviously focused on clinical NHS roles, but it does have key parts of it that talk about how important it is for social care and integrated care systems in achieving that. And combining that with some of the findings of the Hewitt review, one of which was to have a workforce plan for adult social care. That's the thing that's obviously missing at the moment. It's going to be really important for integrated care systems and partners at a local level to be thinking about how joined up workforce planning can work, particularly when the national focus isn't on social care, it's on very clinical roles. So I'm a bit wordy, but I want to just start with saying that. So I guess some of the things our members have seen over the last year, as I said at the start, NCF had really been pushing for a little bit more prescription in terms of the membership of the highest levels of ICSs, and obviously we've now gone down a more permissive route, an attempt to try and build those relationships up first. I think the point of view of our members had been that for many years and decades, there's sort of been an unequal sort of relationship between NHS and social care providers in the way in which social care providers can be perceived by health colleagues and in terms of how valued their voice and contributions are. I think ICSs are a real opportunity to start to rectify that and change that cultural imbalance. And I think, you know, a large concern that some of our members have seen over the last year is that in some areas that sort of, I guess you could call it maybe a health focused or a clinical culture is still an issue for the engagement of some of our members. So that sort of sense that our members are simply commissioned services to do what is needed whenever it's needed, whether that's the flow of people out of hospital or flow of people through the system, rather than strategic partners that empower people's lives and help prevent poor health across the system, and work with commissioners and work with clinical leads in a system to actually develop better services. And so there's a cultural shift that needs to happen. And I think we've been teasing out over the last year, how do we do this? Is it mandated structural changes to ensure social care has its voice? Or is it facilitating that relationship building that needs to happen behind the scenes? And I think more and more as we've gone through the year, we haven't given up on our sort of aims for a bit more structure, but I think there quite clearly is a need to have a sort of a meeting of minds between the different partners, and for the myths and dragons from both organizations to be sort of put aside a little bit. So I think there's just a real need to have I guess just a rethink about how we're doing our partnership working and how we get social care providers more closely engaged in systems and in the work that we're doing. I'm just having a look at some of the other points I've got on my list. I think it's going to become very clear that social care isn't just a means of flow. I think, Jason, you might have used the term of management of flow through systems. And I think we get very nervous with that sort of language, because social care is about person-centeredness. Not to say that you can't have person-centeredness, but the focus is different. It's not about flow. It's about making sure somebody is in the right place they need to be. We want to get away from that flow mindset, even if that is the sort of outcome of where we get to. It's things like that sort of cultural approach to things. It's been good to be involved in the intermediate care program, and it's been good to see adult social care involvement in that. I think the next step would be, how do we ensure that we're talking about prevention and not just discharge? I think that's the other thing. We've been concerned about the sort of discharge focus of ICSs, and then the short-termism of the funding coming from national government through ICSs to providers in order to facilitate discharge, rather than think about the wider sort of community services that could be funded and expanded and widened. And the very last thing I'll say, I think we've talked a little bit about VCSE and VCSE alliances here. I think there's a need for some sort of structure in terms of an infrastructure representation model for social care. So social care providers are represented at the highest levels of the systems, and there's quite clear routes to communicate to ICS leaders. So that's something that many of our members have been asking for. How do we connect with our systems? So I'll leave it there. It's a little bit of a walk around all the things and our thinking about things.
Thank you. And that reminder, I guess, I mean, obviously not every single social care provider feels that they are a strategic leader or partner, but certainly across our membership, we've got some of the biggest not-for-profit providers and charities. And, you know, they are running big organizations, employing a lot of people, supporting a lot of people. It's, you know, hundreds of thousands, if not millions of turnover. So they see themselves very much in that strategic place. And actually talking to members this week, there were quite a lot of reflections on how, as a big national social care provider with a small presence in each integrated care system footprint, how do you set yourself up to kind of manage that? So that's been an interesting challenge. Obviously, if you have a bigger footprint in a smaller place, then you are potentially of more relevance in your local system because you're connecting with more people in that particular cohort of population. That's been an interesting reflection. But yes, I think that strategic leadership's point is interesting. When we've spoken to health colleagues, they often see social care providers as people you buy stuff off, as opposed to people who can bring something more to that party. So yeah, thanks, Nathan. That's a helpful reflection, I think, of the discussions that have evolved over the year, and thinking about balancing that, you know, how you achieve partnership. And I think we all know really that it's very hard to mandate partnership, but sometimes you can have structures that facilitate a speeding up of the building of those relationships. And that's where potentially some infrastructure support might also help. So I think I'm going to go to, if you don't mind, Francis, I'm going to go to Rima next, because I just think the discussion about partnership might flow a bit better. And I was really struck by your point, Rima, that the NHS can do 20% of what we need here in these outcomes, and actually there's 80% that lives somewhere else. So you've had 3 years at least of this partnership building, and you've got, as you described, quite a lot of partners to make that work with. Do you want to just share with us a little bit of your insights that might help providers on this call to think about what they can do, how to manage their expectations, but kind of empower themselves a little in that relationship building in their localities?
Absolutely. So as I said, I also chair Sue Ryder, but I think we cover 8 different systems. They all work differently, and their interest in Sue Ryder's palliative care, bereavement services are all very different. It depends on how high up their own agenda and strategic intentions that, you know, Sue Ryder, well, does Sue Ryder fit that today or not? Clearly, palliative care, you'd have thought, hits everywhere, but it might not be their most pressing, urgent thing in that geography. So I think there's an expectation about where you interact. I'm not sure being at the highest level is necessarily the most interesting level for a provider, because we talk at such high level at, for example, at the board, and who would we ask out of social services, you know, social care providers? It's not one unit, it's lots and lots of different providers. They can't all be around the table. And the granularity of those conversations is not at the level that providers would want to interact at. Where I think providers need to seek to interact is at the local level. So we've got 4 places that match the footprints of our councils. Others have divided up their patch in a different way, but place level is already a good start because you're much closer then to the population, where there's much more granularity in the priorities that are being set, because it's based very much more on the local population. And then you can very quickly work out where you might add the most value. So instead of trying to do something, for example, for the whole of BLMK, you might find that you're better off linking in with Luton, because whatever you offer as a provider really hits the spot for Luton in terms of their demographics and what they're trying to achieve. I totally agree on the prevention piece. We're doing a lot of work on the prevention piece with the BCSE. The NHS has become an ill health service. It's very difficult for the NHS to think about that prevention piece, which is why the place-based partnerships that are trying to look at that, what we keep calling the wider determinants of health, that's where those providers can make the most difference. The other areas to look at are where there are collaboratives. So, for example, we've got a mental health collaborative with our 2 providers who actually cover different patches, but they're coming together to be able to see how they can think through innovation together to make a difference for the whole of BLMK. But they're also linking in with Young Minds, they're linking in with Mind UK, they're linking in with other providers in that work. So they might be driving it, but they absolutely are working with those people. And then, of course, there's all the other work. So our football club, MK Dons, currently offers a program for children from deprived backgrounds who also suffer from social anxiety, and bring them together around sport. We know about it, we support them, they're leading it, they're driving it. So there are so many, it's a matrix. If you think of ICSs as a matrix, there are so many different networks within it that they're not all represented at that board level. We wouldn't want them represented there because they actually know how to do things and they're driving things forward. So we wouldn't want to be meddling with that work. So I hope that's helpful. I know there was a comment at the beginning, we don't want to have to read all of the joint forward plans. And I think, to be fair, a lot of them are probably still at a very, we call ours as a plan for a plan. If you went in there thinking there was going to be a really concrete, granular strategy, we're not there after a year, but it certainly gives an idea of the direction of travel, what we're focusing on. That would help people, providers go, actually in BLMK, they're not looking at anything that's relevant to us. Let's not waste our time there. Let's go over here because they are. Or vice versa. Actually, we could really hook into BLMK's ambition over here. Let's talk to the chief medical director, the chair, the CEO, whoever you think is appropriate, and see who we need to link into within the system to be able to work with them.
Yes, thank you. And I didn't fancy reading all 42, but I suspect if you're operating in a few, then you really need to read, especially if they've got a handy exec summary of their key priorities. But I think that is really helpful, Rima, actually thinking about, how you can empower yourself as a provider and who's ready to have the conversation with you and who isn't, and where your services might best benefit local communities, and where at the moment there isn't an opportunity to think about that. I have to say, I haven't quite got my head around the provider collaborative angle, because that has seemed quite focused on health providers. I'm not sure if you can do that as a social care provider. I don't know, Francis.
So the example I give you is winter planning, which obviously is very immediate prevention. It's not the long-term prevention that we're all aspiring to. But we've got Age UK and the British Red Cross signed up in 2 of our 4 places to help us with that prevention piece, so that people, particularly the elderly, that they are not socially isolated, that we keep an eye on the fact that they are heating their homes and having something to eat, and that they haven't fallen over. So it's small. And
that's come under a provider collaborative umbrella, has it?
Yes.
Okay, that's really interesting.
Yeah, so absolutely, and they're small. I mean, it's not the big ambition we're all aspiring to, but I do think that every year we'll be getting more and more ambitious as we really get into this.
Yeah, That's interesting. Nathan, you've got your hand
I'm
up.
going to be cheeky and ask a question, I think. No, just really interested in what you're saying, Reem, and I completely agree. I think in terms of social care engagement at place at local level, because we've certainly seen that amongst many of a good chunk of our members have that's the bit where they've maybe had the prior relationships and they've been able to build upon that and get involved. Things we've seen some good work with one of our members in London on working with a few mental health trusts and working to get people out of hospital and keep them out of hospital, which has been really good. But I guess my question is more, so if the top level of the systems isn't the place for all the different providers, all the different people, completely get that, there's a lot of people. What is sort of the best mechanism to sort of be raising concerns or raising new ideas or sort of shaping the direction of travel at the top? Because I think the concern probably some of our members have is if everyone at the top is a clinician or a commissioner, how do you get challenged to maybe the decisions or the directions that you're taking? I think that's probably the way I would put it.
I can only speak for my system, as obviously we've all adjusted the legislation to fit our own dynamics. So my ICB has everybody. It isn't just the NHS. So then the question mark is, what's the ICP? And actually we're merging ICP and ICB for strategic seminars. And the intention is the next one we've got jointly together, we'll be looking at that growth agenda, that economic growth agenda. The one after that will be children and young people, but we've set it really high level and I want to push everybody to get to the next level of granularity. You can imagine, just on those two topics, the VCSE or the social care providers that we would invite for one would not match another. If you're talking about the elderly, you would want Age UK, but if you were talking about mental health in children, you'd want Young Minds, etc. So the intention is to try and bring the voice of the resident into that agenda as appropriate, and also invite a few, clearly we can't invite everybody, but a few from the VCSE for those agendas. So they wouldn't be at every meeting because they wouldn't want to be and they wouldn't be appropriate. But then that would help us bring some of those experts into the room when we're trying to think of the next level of granularity. The last thing I would add, though, is that I am not for 1 minute believing that we will in one meeting get to the next level and there it's done. And I think what it will do is lead us to, okay, we think this is the strategic outcome we're going to go to. We now need our 4 places to work that up. And then my expectation is that around that table, again, they would include some of those providers that you're talking about. So there's this cascade, and actually the real shaping of what that looks like probably happens further away from the board than you would imagine.
Thank you. That's very insightful. The idea of a merged ICB and ICP discussion would help to alleviate a lot of those anxieties, I think, which is presumably why you've done that, Rima. Yeah. Jason.
Yeah, just to add to what Rima says, it's very interesting to hear a description of how you're sort of taking forward the legislation, and I think actually what you've done lines up exactly with some of the flexibility we tried to build in. So bringing the ICB and the ICP together, will work for some and not for others. And I think Nathan's question sort of draws out something which, again, it won't be as apparent as it will be in a year or two's time, but is really important, which is it's often about the dynamic between different levels in the system. So how the system relates to its places, and all provider collaboratives and providers beyond that. And I think the CQC will probably take a little bit of a look at that in their system review work. Although I think there's also scope for sort of peers to look at each other and sort of, as it were, test each other a bit on some of this as well. And that's the sort of thing you won't capture necessarily in a governance statement or a constitution, because a lot of it is made not just of the constitution, but also, the long hours and hard work of getting people to work together, as again Rima was describing. But that quality of the dynamic between different elements of the system will be it's the cement, not the bricks, if you like, that will really, I think, make a big difference in the years to come.
Thank you. And just a shout out to Karen, who's popped something in the Q&A. giving us a real life example of, so this is Karen from Karen Radfield Home Care. She's worked with the ICS in Shrewsbury around running a dementia support day and to support their creation of their dementia vision. So partnership in action. Great, thank you, Karen. So Francis, you were going to give us a few examples of, I guess, some of that good practice that is out there. I guess at the moment it might be pockets rather than business as usual, but you've been doing some work with the Care Provider Alliance, which is the umbrella alliance of trade bodies representing about 70% of the sector. And you'd got some examples, I think, of some good stuff going on that people might want to know about, so they can think whether it's something they might want to try and replicate locally.
Yes, thanks, Liz. So I think it's also kind of addressing that question that Nathan brought in about, you know, how do we connect with systems and how do we influence some of the strategic decision making if that is going on at system level. And I think just reflecting on some of the places where that's working, because collaboration is never for the sake of it, is it? It's actually to say, what is it we want to do together to kind of make improvements together for our population, and where do we think by collaborating we're going to have the greatest impact? You know, what are our shared agendas? And that is going to be different for different providers as well. So some, as Rima sort of suggested, might be much more focused on that kind of end of life palliative care pathway. Some might want to be really involved in kind of developing a new model for kind of community services, intermediate care. Some are going to be more focused on prevention. Some people really want to have a voice at the table when it comes to kind of what's your strategy in relation to the health and care workforce. We've seen the NHS workforce plan published last week, and I'm just going to highlight workforce or sort of people boards at system level as being one area where social care providers have found it very helpful to be at the table. So Lincolnshire ICS is an area where they've been doing that. We had another very good example from Staffordshire and Stoke. So in Lincolnshire, they found that having provider representation on the people board's been a really good place to have those sort of strategic conversations with everyone at the table. So you haven't got a kind of NHS clinical domination of that conversation. You're bringing in you're bringing in social care as well for the kind of, you know, looking at the strategy, but then that's supported by working groups. So you might have different providers involved in different working groups, depending on kind of areas of interest. So some of the things that they've achieved in Lincolnshire is they've worked together on a nursing associate programme. That's kind of where they started out with care certificates and nursing associates when they were both new concepts, and then they've kind of built on that experience of working together on those shared agendas. And they're going on to look at things like combined engagement with schools around awareness of social care as a career choice to kind of feed into recruitment. They're working across the system on international recruitments to make sure that they're not kind of reinventing the wheel, you know, between different sectors, and what are helpful approaches to international recruitment. And they're looking at working together on things like onboarding resources for new staff. And in the future, they want to kind of look at better data from social care to inform workforce planning better. And in Staffordshire and Stoke, they've kind of worked together quite fruitfully on recruitment campaigns into both the home care and the care home sector, and kind of really collaborating to make sure that you know, that the recruitment is done in a helpful way, that doesn't sort of destabilize the provider market, if you like. So lots of scope there in kind of workforce strategy for collaboration, and that's happening across quite a few areas. Another area that providers have found it fruitful to collaborate and kind of worth their time to invest at being at the table has been around the whole digital transformation agenda. So we had a really good example of how that was working in Lancashire and South Cumbria, where they're kind of working on digital adoption and transformation with the regulated social care market. So that again, they've taken an approach across the whole of Lancashire and South Cumbria to kind of really look at how a provider supported with skills and knowledge to kind of become digital, you know, how they supported around things like data security, how can they work online safely, have they got the right infrastructure in place, are they really drawing down the transformation funding that's available for digital transformation and putting it to the best use, and kind of ensuring that providers have got a voice in all that decision making. They're represented on the kind of system-wide steering group alongside local government and NHS colleagues, so they can really be involved in shaping how all that pans out rather than being done to or being kind of on the receiving end of a much more transactional contracting relationship. And kind of moving on to, you know, things like making sure that shared care records are in place. And there's an awful lot of scope around digital transformation beyond the kind of shared care records, kind of into digital, you know, digitally supported care, whether that's kind of care at home or in care homes. So that's been another big agenda for collaboration. And then on the issue of kind of how does the sector connect with systems and do it in a representative way, a lot of areas have found it quite useful to kind of build on the Care Association Alliance structure that often already exists. So in the Northeast, they've kind of taken a Yorkshire and Humber wide approach. And they have and they're linking into the 3 ICSs in that area, again making sure that they're kind of represented at the system level and that they can be having conversations, and they're having strategic conversations around a whole host of shared agendas. Actually, they've kind of liaised on fair cost of care. They're making sure that they've got the right representation in different work streams, so they don't all have to try and go to everything, but they kind of know, okay, who from the sector is representing us at that people board, for example. They've in some areas of course they're talking about hospital discharge. They're talking about workforce. They're looking at new commissioning, future commissioning strategies and frameworks, and they're collaborating on new legislation and practice around things like funding reform, liberty protection. So there's kind of collaboration across quite a wide area of sort of strategy, policy and practice, and it's supported by the existing structures of care associations. So that feels like a really promising direction to go to make this a little bit more systematic, and actually provide a bit of a, you know, ICBs find that helpful, because frankly quite often they don't know where to start and who they should be talking to.
Thank you. And that, yeah, all those examples sound great, Francis. I mean, there is a pressing need around workforce and joining up the workforce. But given that we've got huge workforce pressures, and even with the NHS workforce plan, it's not entirely clear it's going to solve the health workforce pressures. So we've got to make the most of our very skilled workforce across both health and care. And there's got to be more efficient ways in which we can do that. It's just that sometimes the money has to flow. You know, if we're delegating healthcare activities to care staff, we've got to find a way to recognise that extra responsibility and skill, for example. But it's all entirely possible, and it will actually probably be much easier for the people on the receiving end of that healthcare and support and treatment, because there's one person supporting them. So I think the opportunities are massive. And thinking about that infrastructure point, I mean, we've had some good examples. I guess one of the things that oils the wheels is a little bit of funding to make that infrastructure a bit more reliable and sustainable. So great to hear. Thank you.
And if people want to know a bit more about the detail of any of those examples, all those 3 areas I've talked about are actually kind of available online, so we can share the link to those resources if you want to dig a bit deeper into that and be put in touch with some of the colleagues that are working in this way.
I think that'd be very helpful. Oh, Nathan, I'm just about to go on to our final chunk.
So I got another question.
Okay, go on.
So I'm just thinking about social care providers who may bridge more than one ICS area. I'm thinking particularly of maybe digital transformation, the technology fund, I think it's called, and say I know there's examples of organizations that may want to adopt, either move to electronic care planning for the first time or adopt a new type of technology, but they need to do that throughout their organization for the business case to make sense. But if some ICSs won't release that funding for one reason or another, I guess what would they do? Is there a mechanism to try and ensure that
you're talking about the devolution of digital funding to ICSs, yes, and not having idiosyncratic decisions.
Yes,
absolutely.
Because there might be slightly different strategies or approaches or priorities depending on which area you are in.
Yes. Did that come up at all, Francis, in thinking? Because I know it was Lancashire, wasn't it, and South East Cumbria. I know they've been doing a lot of collaborative work across their ICS, but if the one next door has a different priority, then you might be a bit in a tricky position if you operate across both areas. So did that come up at all?
It did come up when we were looking at that particular example, because we did kind of take a system footprint to see what was happening at system level. But I think that there are some kind of regional infrastructure things being put in place to support the digital transformation agenda. So I'd look at what regional routes there are, and quite often ADAS's regional support teams are involved in this work as well, so they could be a good starting point to try and kind of unpick some of those challenges around kind of different approaches between different systems. And I know it's something that the National Digital Transformation team would be keen to help with as well.
Yeah, we've flagged a few. It's generally if you're a bigger provider, to be honest. Okay, so I guess in our last 20 minutes or so, we've got an opportunity to think about the year ahead, year 2 or year 4 if you're REMA, and probably quite a lot of other systems. I don't actually know how many are entirely new, only 1 year old. You might know, Jason. So what, from the department's point of view, there's been a massive policy change, and you've been leading it through its process, its legislative process, and working closely with Francis and her colleagues in the NHS around kind of making it happen together. So what would you say to our audience about the year ahead? What do you think? What do you think it might bring? What might they want to think about? Anything from Hewitt that you think's really going to bed in? Reflections.
Interesting. Someone once said you shouldn't make predictions, especially about the future, but there we are. So I'm going to give a slightly perhaps dull answer, but I think it's probably quite importantly dull, which is that it's sort of about the slow iterative progress forward, continuing. And also, yeah, I mean, you asked how many were brand new. I think almost none were completely brand new, in the sense that STPs have been around in one form or another. But the thing that does vary a lot between systems is if you like, the maturity of the relationships between the partners. So for those that are still working on that, then that is often the thing that's going to need to be focused on. I suppose the things that it would be nice to see, or might be signs of positive progress, would be stronger links between some of those immediate urgent operational pressures and then some of those kind of more medium, maybe even to long-term changes that we need to see as well. And we've talked about, colleagues have talked about some really good examples of that over the course of this discussion. And I suppose the thing that's always seemed to me to be like a really promising feature of the ICS model, and actually the ICS, one might even call it a movement, although I'm not sure if someone from the department calls it a movement, that'll probably kill it stone dead, won't it? But that sense of learning from each other, getting on with it, sort of almost irrespective of, if you like, what people say nationally, not quite, but a bit. And it goes to some of the points I think that Francis was making about connections with, say, the education sector, a sort of integration outwards as well as, if you like, between some of the more obvious partners within the system. So a sort of, I suppose, a growth in some of that kind of specific small, pathway by pathway kind of wins and progress, but also a sort of growing confidence and a growing sense of being the conveners and shapers of the system. I think that would be my hope for the year ahead. And I think there's every chance that we can get there, even with some of the stronger difficulties that are in the system.
Okay. I was just thinking about all the things ahead. We might come on to winter planning. I've got a few thoughts about that. Nathan, have you got any top tips for providers?
Yes, so I think it's very, very important for social care providers to actively engage with their systems, not only for the fact that this is where a lot of funding is coming through, it's also where the government's looking to enact some parts of its reform plans, but also it'll just enable us to tackle some of those sort of cultural imbalances I spoke about before. So I think if providers are waiting for the integrated care systems to come to them, they might do, but I think that's definitely the wrong approach. You need to be making the case for why you want to be involved and listened to in the wider bits of the system. Reach out to the other care providers, reach out to the care associations and other provider forums. Engage with your commissioners and engage with people throughout the system. Think about ways in which you can add value to other projects or other things that are happening. The intermediate care program we've already mentioned is one of those. What ways can your services, whether they're residential or community based, actually enhance the sort of aims of the wider system? And I think it's having that attitude and that approach that then brings you in, builds the relationships that allows you to be brought into the decision-making conversations and to show that you're a key strategic player. And I think perhaps for too long, maybe some providers and maybe NCF's been, when we were initially thinking about this, maybe we took the wrong tact. But I think it can be quite easy to sort of say, well, we deserve to be listened to because of who we are and what social care is, rather than thinking about what you're bringing to the system and how you're helping other partners. So I think there's a culture shift for social care needed, as well as for the other partners. So I think that's the main thing. And then, I mean, social care needs reform. So keep shouting for reform for social care from your local politicians, please, local and national, because that will benefit the system as well.
Thank you. I do think that is, the find your voice message is really important, isn't it? And actually, I've learned from Rima, and you should go and read your XX summary of your integrated care strategy for your locality. You might not have to read it all, but you can probably Control F and find the priorities.
I should also
probably take you 10 minutes. Yeah, go on,
you can
Nathan.
also listen to your, I believe the ICB meetings are recorded and live. They're public meetings. So go and listen to what the priorities and what they're talking about, and see how you can get involved.
Oh, you can do that with the CQC board as well. I hope yours are more interesting, Rima. So yeah, I think make your voice heard. That proactive point is really important. I'm going to come to Francis in a minute, but I just wanted to reflect on the intermediate care pilot work and thinking about winter planning, because we did embark on that intermediate care pilot work in a bit more of a co-production way, certainly involving social care. But I think there's been an immense pressure for a bit of more NHS focus. It's had to retrench a little, I think, partly because of restructures and just because of immense political pressure, I suspect. And I would not expect any of you to comment. I can say that. You don't have to. But I do think from the involvement that we did have in the early phases of that, there are a couple of key points I think would really help and are something that providers could offer to their local systems. One is that whilst we all want people to get home, the route for getting home can be a number of ways. And there are some fantastic intermediate care services that social care providers offer that are not long-term residential services. They may be in a unit or a wing of a longer-term setting, but they are a 4 to 6 week accommodation-based rehab, reablement and recovery service. And I think there is a nervousness about that in local systems for all sorts of very good reasons, but don't overlook the potential of those services to really support people getting back home and back on their feet and back to a level of independence we would all want. And we are at the moment, we're finalising a kind of blueprint for what that might look like, what you might need to sign up to as a care provider to deliver that, and what you might need from your system. So I think that winter planning point is really important. And alongside that is the fact that decisions need to be made quite early to support investment, to create that additional capacity. So part of the reason we've had problems before is because those decisions have not been able to be made till October or November, whereas they need to be made in, July, August, September. So we learned quite a lot of really useful things from our limited involvement, and we would really urge our members and other care providers to think very carefully about what they can bring to the party when we're getting closer to that winter pressure time, and start thinking about planning it now. That's been a real learning for us. And I think, I guess one of the other points is, if it may be the time to engage proactively with your system locally. It may not be ready for you, but you need to be empowered with that knowledge, and you make that decision. And as Nathan says, don't expect the system to come to you necessarily. So Francis, I'm just going to ask you for a couple of reflections, and then Rima can give us a final view. So any top tips, any things you're thinking of for the year ahead?
I think probably my main reflection is repeating the point about, finding that shared vision and agenda. So what is it you want to improve together, and where's that common ground that you can actually work on to do something, and that's where the relationships build in practice. And I think it's about that, not so much as about looking to governance to find the answers to this. I'd look at opportunities to collaborate in practice and build relationships. So that would be the first thing. I think for the provider sector, it's really important to collaborate, to find that more powerful voice, recognizing the pressures on providers of the many things the many directions that you get pulled in, just from a purely operational point of view. And you want to know that if you're spending time sitting around the table on a workforce board or whatever, it's time well spent. That is there a colleague in the sector that's doing that, so that you don't have to? Can you join up? Which is part of working strategically rather than kind of transactionally, and that goes for the NHS as well, of course. And then I think there's something about building on what you've got, because we're not starting from a blank sheet of paper. This is in a way, isn't it, the latest turn of the wheel in terms of how do we integrate health and social care. That we've had lots of goes at it over the years, and partnerships and alliances have been built. They look different in different places, but if you've got a place partnership working really well between health and social care, don't throw it away, build out from that. If you're collaborating really well already on workforce or on digital, and you've got some infrastructure in place to support digital transformation, can you build out from that to kind of support the collaboration in other areas where the sector wants to have a stronger voice, or indeed, as an NHS partner, you want to link more strategically into the sector. So kind of a really strong message we've had when we've talked to people locally and nationally is build on what's there. So those would be my main concluding reflections, I think. And we're going to be trying to, find more examples of practice in the year ahead that show where that's happening. Because going back to Jason's point about kind of creating a learning system, it's about learning from what works well and spreading that.
Thank you. Build on what you've got. Sound. So Rima, the year ahead for you with your juggling unicycle, fog and uphill.
I agree with everything that's been said so far. I think the thing that everybody needs to remember is that the success of any initiative of these integrated care systems is actually about the human relationships. It's the people that you know, how well you know them, that will make you get into the right spots, if you see what I mean. So, the networks that you build up around you. Our most successful collaborative working is usually between individuals who want to make a difference, who will get on well together, who can agree to disagree and find better solutions together. And you can have in the same system other individuals who really would rather not be in the same room, and therefore, no matter how compelling the solution might sound, if if those individuals won't get on, you can't make it happen. So my first recommendation would be really carry on with the networks you've already got. It doesn't matter if you're not at the top in the boardroom, because I really do believe the real changes are happening on the front line. All we're doing is enabling it. We're enabling the funding to go to the right places if we can. We are trying to get expertise and resource to places that need it. We are, if you like, the orchestra, the conductor of the orchestra, but we're not playing the instruments. The year ahead, I am pushing very hard, at least in my system, that we get beyond the plan for a plan, so the actual plan. In other words, the next level of granular detail of our ambition, so that people can start to go, okay, well, if that's what you want to achieve, then these are the programs of work we need in our different places. And that will also include a better defined clinical strategy and a better defined financial strategy, that within the constraints that we have, both in terms of volume of funding, but also the rules in which we can spend that money. How do we start putting more money out of acutes into the community? How do we put it more into prevention and less into ill health? And it's going to take a while to shift that, because obviously when you take it from one place to another, you don't want to destabilize the place you're taking it from. I'm very optimistic we're going to gather speed now that we've got through the governance setting up, and we've got through how we're going to work together and our relationships. Of course, we have a general election coming up, and I think that be great. It could, be that certain knotty issues that are being ignored at the moment because it's coming will then be fixed quite soon afterwards, or we could have a whole new view of how integrated care systems work. I always try and shield my system from as much political noise as possible. Again, because the frontline are the people and the parts of the organisation that are delivering. But even I can't shield them completely if the political noise gets very different. If the political tune changes, then we will just have to adapt. But I'm still very engaged in getting us to where we want to get to.
Thank you, Rima. Yes, and a timely reminder. Things could all change, but I mean, there are some, and Jason's done a cracking job of getting all the legislation in place, and that's much harder to unpick. So it's as you say, different political pressures can sometimes enhance or constrain. Okay, well, thank you, everybody. I think that's been actually a very insightful discussion. I've learned lots of things from all of you. I really like it when we do these kind of discussion webinars, because you actually get to reflect on what people say and you hear voices that you don't always hear. So I'd like to say a massive thank you to you all for giving up your time. I think, Nathan, we might want to craft a few top tips actually from our various reflections. I think that might be really helpful as a little product from this webinar, because I think we've got some gems here. So maybe we'll check in with Lisa. Lisa, do you need to come and say thank you to anyone? Do you come back on now? Oh, yeah, you do. There you are. Yeah.
Yeah, just a huge thank you to you all for taking the time to be here today. As you said, there's a lot going on and a lot to do. So yeah, thank you so much. It would be great if we could do, as you said, Liz, maybe do some top tips for providers, how they can kind of be involved. So yeah, we can do something and maybe plan that in and pop that on the CMM website alongside this discussion as well, so people can see it all at the same time. So we will liaise with you to get something together, if that's okay.
I really think that would be handy, because we've got some really useful insights, different perspectives from the colleagues on the call, and I think that's really valuable.
Yes, absolutely.
I think some of the case studies Francis has as well would
yes, we could link through to those as well. Yeah. Are you happy for us to do that, Francis? Connect it all together?
Yeah. Very happy. Just let me know and we'll make sure you've got all the links.
Fantastic. Well, thank you, everybody. Thank you to our audience. Thank you to our sponsors. Thank you to CMM. But most of all, thank you to Francis, Nathan, Jason and Rima for their time and their wisdom. Really helpful. Thank you all and have a great day.
Thank you to you as well, Liz, for expertly chairing as always.
Oh, you're too kind.
Thank you, everyone. Take care.
Take care. Bye-bye.
Bye. Bye.
Bye.